Hi, everybody. My name is Michelle Farrington, and I'm the Public Health Promotion and Community Engagement Lead for Oxfam. And today I'm going to be presenting on behalf of the research team that has been looking into understanding the barriers for inclusion of older people with incontinence in humanitarian WASH programming. So firstly, to introduce the aims and objectives of the research. So often WASH activities are set up on the assumption that standard designs can be used by everybody, whereas in reality, older people are rarely asked what they need and how they use WASH facilities. Many may not be able to leave their shelters due to mobility issues or disability, or because they are caregivers for grandchildren. Coupled with this is the issue of incontinence, which is a complex issue that has social, emotional, economic, and practical challenges for the individual and significant implications on their WASH needs. Despite this, there's limited experience and evidence about the scope of the problem and its implications. So this research aims to hear from older people themselves on their experience of living with incontinence and to develop a practical, sensitive methodology to understand this issue in humanitarian settings. Through the research, we hope to investigate how the WASH sector can better engage and support with those with incontinence, understand the coping mechanisms that people have in order to support and supplement these where needed, and to be a catalyst to bring a focus to the needs and priorities of people with incontinence in humanitarian WASH programming. The research is taking place in Ethiopia and Malawi and is aimed to be completed by December 2021. This research project is bringing together a wide range of partners. The lead investigators are Oxfam and HelpAge, and bringing together their experience in working in emergency WASH and with older people. We're working with partners in both countries, the Federal Ministry of Health in Ethiopia and the Malawi Network of Older People's Organisations, MANEPO, and St John of God Hospitaller Services, who are bringing expertise in public health, older people services and mental health respectively. We've been supported throughout by Dr. Amita Bhakta and Dr. Sarah House, who both have expertise in incontinence, inclusion and equality issues in WASH. And lastly, but by no means least, we're supported by ELRA's Humanitarian Innovation Fund and the Institute of Development Studies, who are supporting in funding the research and also capturing learning on the research process itself. This research is planned in several stages, but it's unfortunately suffered quite substantial delays because of COVID-19. We've already completed the landscape scan and the literature review, the tool development and the testing, and some initial research that has taken place in Ethiopia. And alongside this, IDS are helping us to support capture the learning throughout the tool development process so that we end up with a more refined and participatory tool that can be used by the WASH sector at the end of this year. Before presenting some of the findings from the landscape review and the tool testing, I wanted to introduce the issue of incontinence. So incontinence is the involuntary loss of urine or feces or both. It's a very complex health, protection, social and dignity issue, and it can be highly stigmatizing and cause a range of challenges for the person who is living with it and their families. There are different kinds of urinary and fecal incontinence, ranging from an inability to fully empty the bladder, which is called overflow incontinence, a sudden urge to empty the bladder or the bowel, and stress incontinence, which can be caused by sneezing, laughing, coughing, or exercise. People with incontinence need more privacy, more soap and water, more time to manage their hygiene and their daily activities. But in humanitarian settings, older people may find it difficult to access WASH facilities in a safe and timely manner. Furthermore, the level and severity of incontinence can hugely vary. It can happen during the day, at night, or at both times. It can range from occasional leaks to more regular leaking that can cause odours and rashes, to more severe infections. Where people are bedridden, incontinence can interact with bed sores, causing severe infections that, if not treated, can be fatal. Whilst this incontinence is focused on the incontinence needs of older people, this is not only an issue limited to older populations. The list on the right gives a full but not exhaustive list of other population groups who may suffer with incontinence. Our research has begun with a desk review of available literature to try and understand the evidence that's available about the issue of incontinence in humanitarian settings and its implications. The review has found that data on the issue of incontinence is very limited. A study by Rosato Scott puts best estimates at around 25 to 40% of women and 1 to 39% of men having some form of urinary incontinence, and around 15% of adults having fecal incontinence. A large proportion of the data we have has been drawn from HelpAge's studies with older people. However, these also have limited amounts of data relating directly to incontinence. In Cox's Bazar, 17% of older people said they were living with incontinence, and a staggering 77% of them said they were struggling and they didn't know where to get support. In Gambella and Cyclone Idai affected areas of Malawi, data from HelpAge surveys show that in both locations, older people have difficulties accessing wash facilities and healthcare, with bathing facilities being the ones that have the highest safety concerns. In Ethiopia, large numbers of older people are also caring for dependents, and in Malawi, 35% of older people are living alone. In both contexts, over 50% of respondents said they had not been consulted at all by humanitarian agencies. More recently, we've undertaken the first field-based portion of our research with a 2-week visit to Nunyel and Kule camps in Gambella, Ethiopia. And the purpose of this trip was to undertake key informant interviews and to test the participatory tools to determine their suitability for use in the main research visits. We trained 6 members of staff to lead this stage of the research, and we conducted 4 focus group discussions and 6 key informant interviews. So I should say that the data that we're going to present is by no means representative. For key informants, we ask questions on their understanding of incontinence, their experience of working with older people, and whether incontinence was included in guiding documentation. So there was a mixed level of understanding within the WASH sector about what incontinence was. For the most part, respondents related incontinence to their personal experience, either what they'd seen working alongside health practitioners or through the experiences of family members. All WASH practitioners noted that they did not currently undertake any activities directly related to incontinence. Within the protection sector, the understanding was higher and mostly came through previous work experience. However, they also noted there were no activities directly related to incontinence. They did note that some services for older people may address issues of incontinence, for example, the provision of commode chairs, which were often distributed for disability or mobility issues. There were some good examples of WASH and specialist agencies working together to support the needs of older people with mobility issues. Participants noted a project between Oxfam and Humanitarian and Inclusion to provide accessible latrines, and specific interventions by HelpAge and RADO. Within the protection sector, there was a clearer understanding of the different living circumstances of older people, such as those living alone or with dependents, etc. All WASH actors noted that incontinence was not included in any assessments, training, strategies or policies, with the exception of the Oxfam SaniTweaks training delivered in late 2019, which was delivered to WASH cluster agencies. Protection actors noted that incontinence was mostly understood by the term people who are bedridden, and that outside of this it was not well understood. Both WASH and protection actors noted the need for more evidence and advocacy around the topic. 2 WASH sector respondents noted that having accurate data on the scale of the issue was important to enable the issue to be discussed further. The research team met with 38 older people in total, and the focus groups were purposefully kept small to ensure participation, but also to comply with COVID-19 regulations. When we asked who they thought was living with incontinence, the groups also focused on this being linked to being bedridden. However, in one focus group, a female participant noted it's better not just to say bedridden. There are lots of people who can walk who have incontinence. And after further discussion, all groups gave a range of different individuals and circumstances that they were aware of, ranging from young people, those with disabilities, and those who have either frequently given birth or have given birth while still very young. In each group, at least one individual mentioned the link between incontinence and old age, often noting that this was because the body was becoming weaker. In one group, a female participant noted herself that she herself was incontinent. When asked about the challenges and impact on the lives of older people, all four groups focused heavily on the psychological impacts of incontinence. Most participants expressed that challenges related to feeling distressed and lonely or being neglected by one's family or community. Suicide was mentioned repeatedly in three focus group discussions, with participants offering examples of where they had seen this happen. One extremely saddening remark by a female participant was, when no one is taking care of older people, they go themselves into the bush at night to die. All four groups agreed on the most common coping mechanisms for incontinence were using jerry cans or buckets cut in half to use as temporary bedpans, or using cloths and animal skins to protect clothing and mattresses. There was a heavy reliance on caretakers for taking individuals to the latrine, emptying bedpans, changing and washing a person's clothing and bed sheets. Almost all aspects of WASH programs were raised as being gaps for older people with incontinence. Participants in one group disagreed about the need for adapted latrines. Some said that they were required and others said that they were not useful if the person could not move. Soap and additional clothing and bedding were raised in all four discussions, often associated with preventing odours related to soiled clothing and bedding. In terms of improving the situation for people living with incontinence, access to wash items listed high in each focus group. However, so did the need for stronger psychosocial support. Being with people your own age, either during household visits or through group activities, was mentioned in each group as being a way to address some of the negative aspects. One male participant noted, "We need to be with them, advise them that having this problem is not the end of your life." However, all groups were in consensus that this could only be effective with further WASH and medical support. As the research is in its initial stages, there are no conclusions or recommendations to share at this point. However, we would like to share some reflections on the process in Ethiopia. Firstly, that communicating about incontinence in other languages has its challenges. There is no one word for incontinence in Nuer, and the teams often had to use descriptive language to explain the problem, which often led to confusion and inconsistencies. Eventually, we found words for uncontrolled urine and uncontrolled feces. However, more work needs to be done on finding the right ways to talk about the issue. The perception of incontinence being equal to that of being bedridden seems to be quite entrenched in the understanding of key informants and participants. Whilst many bedridden people may be suffering incontinence, incontinence is also present in a much wider range of people who may be missed. Linked to this is that incontinence is a sensitive topic and potentially embarrassing or distressing for people to talk about. And for this reason, it may continue to be difficult to identify people who are willing to participate or volunteer information on their experiences. However, it was interesting to see some light bulb moments with WASH practitioners, even during this initial stage. One WASH practitioner said, "I didn't understand the severity of it, even though my own mother had mentioned it. Now I've heard from people, I really hear how it can affect their life. When I hear that people are not eating and not drinking, it makes me think that my mum was also doing that. It's a shame that we don't know about it." There is still a lot more work to be done on this research project, including further key informant interviews in both Malawi and Ethiopia. And the full research visits will take place later this year. Our aim is to hear from as many older people as we can to build a picture of their experiences and to inform the tools and approaches WASH practitioners can use to best support them. Thank you.